episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. Now, today is the third show in a series of 3 on Myeloma Crowd Radio for the Myeloma Crowd Research Initiative, or as we like to call it, the MCRI. And you've heard about this because we've just had 2 recent shows, but when we started the foundation and after we built our scientific advisory board, we were asking them what we could do as the myeloma crowd to fill gaps in research funding. And the first time we did this, they told us we should go fund high-risk research, which we did, and we were the first ones to crowdsource and crowdfund 2 immunotherapy projects. One was a CAR T project from the University of Würzburg in Germany, going after 2 targets for CAR T cells, CS1 and BCMA, and the other was the immunotherapy called MILS from Dr. Yvonne Borrello at Johns Hopkins. Now, the second year we asked the same question because we knew there were existing foundations and good groups out there doing wonderful things in myeloma. We really just decided to find the unmet needs and fill those needs. And Dr. Fonseca at our meeting suggested that with so many new treatments in the myeloma landscape, that we really needed a tool for patients who were not seeing, especially who were not seeing myeloma experts, to be able to understand different treatment options they had that were more personally relevant. Because so many, over 80% of us, are treated in community oncology settings and who might not be seeing a myeloma specialist. Now, it is still the best thing you can do for your own care to find a myeloma specialist and consult with them as you're making these key treatment decisions. But his idea sparked the idea to develop this tool called HealthTree, which we have now built and have over 2,200 patients using. And there are 3 purposes, really, or benefits to joining HealthTree. First, you can understand personalized treatment options to have better discussions with your doctors. And second, you can find clinical trials that you're eligible to join. And then third, just by aggregating our data, even in a de-identified or anonymized way, we can help identify or researchers can help identify new potential hypotheses for different types of patients. And the show today is a little bit about that theme. Now, our focus for this second Myeloma Crowd Research Initiative, we're calling it Optimizing Myeloma Care, is very complementary what we've done for HealthTree. We wanted to see how else we can come to more personalized or precision medicine. And precision medicine has been stressed so much lately, going after specific genetics. We'll talk about that sometime today. But some of it is also getting this more holistic view of the patient and not just and first and only the genetics, but a broader view of the patients. So you recently heard from Dr. Chung on his testing of the immune system, and earlier even this week we heard from Dr. Zahn and Dr. Jathava to learn about killing these precursor myeloma stem cells. Today is our third project that we are funding with Dr. Cesar Rodriguez, and he is working on 3D tumor modeling. And each of these 3 projects bring a unique and different approach to personalized care for you as a myeloma patient. Now, if you'd like to support these projects, you can go to give.crowdcare.org/MCRI, and you can donate, or you can create a page, or you can create a team fundraising page, and then you can share it in any way you want, and the holidays are a great time to do that. So with that, we would like to welcome Dr. Rodriguez today, who is doing some truly remarkable and unique work. So welcome to the show.
Thank you very much for having me, and thank you very much to your organization for supporting research that's outside of the box, like the one we're doing here.
Well, we think it's super cool, so we're excited to hear more about it. Let me just give a little bit of a bio background on you before we get started. Dr. Rodriguez is originally from Mexico and has done significant training at Mount Sinai, the Cleveland Clinic, Harvard Medical School, Memorial Sloan Kettering, Massachusetts General, Seattle Cancer Care Alliance. So many of these top institutions in the United States. And he's currently assistant professor in the section of hematology oncology in the blood and marrow transplant division at Wake Forest University in Winston-Salem, North Carolina. He is an associate member of the graduate faculty of the University of North Carolina at Charlotte. He's a committee leader for immunotherapy and myeloma for the CTN Myeloma Intergroup. He's the lead for the myeloma research at Wake Forest School of Medicine. He is on the ASH Leadership Institute. He is a CTN Myeloma Intergroup member. His awards include the first place junior faculty category for internal medicine research at Wake Forest. And he has also been awarded a National Patients' Choice Award and the Leukemia and Lymphoma Society Man of the Year Award. So we are really grateful that you are taking an out-of-the-box approach to myeloma care because patients still are not totally cured yet. And it's becoming clear that patients, even though as good as the therapies are, that relapse still happens, and that we need new thoughts around this. So thank you so much for all you're doing. It's just truly incredible.
It's a pleasure. And it is true what you're saying, that drug resistance is a big challenge when dealing with multiple myeloma. And that's kind of what stemmed the concept of this research. A lot of the times we all have a pretty general idea of what to do when somebody has a new diagnosis for multiple myeloma, but then once somebody relapses, that's when everybody starts having a trouble determining which is the next best therapy. And hopefully, we're hoping that this study and the results of this study is going to help answer this question for not just the specialists, but any oncologist in the community that are treating a patient with multiple myeloma.
And it's not really clear the causes of resistance in all situations, is it?
So resistance has a lot of factors. It could be a multifactorial thing. And a nice way to understand resistance in multiple myeloma is there's two things that need to be understood. One is that when we're dealing with multiple myeloma, we're not just dealing with one strain of cancer cells, but we are dealing with a variety of strains of myeloma cells. And there's different groups of cells that have certain characteristics, but not all of the myeloma in a patient's body is going to be the same. So whenever we do chemotherapy, we might be targeting just a percentage of those strains and not all of them. And it's almost like when we have a pest control problem at home and we're trying to get rid of the whether it be cockroaches or bugs or whatever, and we are selectively choosing the most resistant bugs to pesticides. And that is kind of what happens with chemotherapy. There are mechanisms for the myeloma cell to develop resistance, either by protecting and shielding itself from the environment that's providing the chemotherapy so that the chemotherapy doesn't penetrate into the cancer cell. And it also causes the same shielding process can prevent the immune system in the body to identify the myeloma cell and be able to flag it so it could be destroyed. So it's a combination of us not treating all of the different strains of myeloma and then letting the remaining strains grow without any opposition from the dominant strains that were there before, and also the mechanisms of mutations and the ability for the myeloma cell to guard itself from whatever is trying to attack it, whether it be chemotherapy or their own immune system. Mm-hmm. But there's definitely still a lot to learn about the exact mechanisms of resistance, and hopefully this 3D model is going to help answer some of those questions.
Yeah, I agree, and I believe it will. When you look at myeloma and you talk about the genetics of these different strains of myeloma, how important would you say it is in terms of personally treating myeloma? Is it the only factor? Are there other factors that we need to be considering, like the immune system or other things like that? Or do you think the best approach is to target these, like figure out the genetics of each clone and then go after those particular genetics? Can you just give a broad overview of what you believe as a researcher?
Sure. So the genetics of a type of cancer are important, and it is something that we can never ignore. because
Right.
depending on what mutations are present in the cancer cell, we can have an idea or can predict how that cancer is going to respond. If it's going to be a very aggressive type of cancer that's going to be hard to treat, or if it's going to be one of those cancers that might be treatable but then going to want to come back and relapse sooner. But having said that, the genetics is not the only thing that determines how aggressive a cancer is, and we cannot ignore other factors because, and I'm pretty sure patients who have multiple myeloma and have talked to other patients with myeloma have seen that they might have some aggressive mutation and still achieve a remission, and then there's other patients who have mutations that are not considered aggressive and still behave like a stubborn disease that is hard to treat. So there's a series of factors, but one thing that where we're trying to gravitate is towards personalized medicine and also to targeted medicine. And when we talk about targeted medicine, we are focusing on actual specific mutations that a particular drug can target. So let's say somebody has an aggressive mutation like a 17p or has a mutation like a 13q, and we identify a therapy that can target that particular mutation. At the current time, we don't have one that targets those particular mutations, but we do now have therapy that can target translocation 1114, and that would be venetoclax.
Mm-hmm.
It's still not FDA approved. It's still in study, but it is the example of the first targeted therapy that we can potentially be seeing in multiple myeloma. So that's very exciting, but we also need to understand that, like I had said earlier, because multiple myeloma is a series of strains and not just one single type of myeloma pattern, if we were to target just cells that have the translocation 1114, we could be missing therapy for other strains of myeloma cells that don't have that translocation. So I think targeted therapy does have a future in myeloma, but it's always going to be important to combine it with other agents so that we can target those particular mutations but not ignore other strains that might not have those mutations.
Yeah, and that makes a lot of sense, and that makes a lot of sense why doctors are using triplet combinations and, even 4 therapies in newly diagnosed myeloma as well as relapsed myeloma, because
Correct.
It sounds like you're just trying to go after all the clones, right?
True. So the more ways or the more angles you target the cancer, there is a better chance that we might actually be able to cover all of the different strains. And even if it was just one main strain that a patient might have, which is rare, but let's assume that there could be just one predominant strain, it would still apply using a combination therapy, triplets, or now that we have monoclonal antibodies, the whole concept of going back to quads, which was debunked years ago. But it is good to target a cell from different angles, cancer from different angles, so that we can have a better chance of destroying the largest amount of cells possible. Because the deeper the response and the more we clean the bone marrow from myeloma cells, the better the probability that we can keep a patient in remission for a longer period of time.
Well, I'm so excited for people to hear about what you're working on because I just think it's brilliant work. Maybe you want to describe first the current problem with studying myeloma drugs and trying to study drugs. When you take the myeloma cell out of the body, what typically happens when you're trying to compare therapies against that?
Yeah. So let me go back a little bit to anatomy. And multiple myeloma comes from an abnormal plasma cell. And the myeloma cell tends to live inside the bone marrow. And the reason why that is that the bone marrow has all these nutrients that make the myeloma cell be able to survive. It feeds off of those nutrients. It actually interacts with the cells that are surrounding it in the bone marrow environment, and by communicating with the cells around it, it kind of manipulates the environment there to its advantage. And it has the ability to get the nutrients that it needs to grow and divide and multiply. but it also has the ability to protect itself and make this shield that I was mentioning earlier that gives it resistance from the immune system and resistance from chemotherapy itself. So when you have, if you were to look at the cancer cell in its natural environment, you have the cell that is touching other cells around it, and it's communicating with all of the cells around it. So imagine you being in the subway at rush hour, and you're jammed in one of the carts, and you have people all around you that are touching you. And you're going to push a little bit to make yourself some space, and that's going to influence and affect the person that's next to you, and they might either yell back at you or they might actually push away. But you're going to influence your surrounding based on what you do when you're there, touching just around all these people. And that's kind of what the myeloma cell does in the natural habitat. Now, when we're studying chemotherapy and new agents to treat multiple myeloma, we use myeloma cells and we put them in a Petri dish. And the problem with that is that it is a two-dimensional culture that we're doing, or a two-dimensional plate, and you don't get to see the interaction of the myeloma surface in all of its areas with the surrounding cells. You have very little interaction between cell and cell, and they tend to be myeloma cells the way we grow things. And so you're actually already altering how the cell behaves in its environment. So when you expose it to chemotherapy or new agents to see if it kills the myeloma cell or not, you're not really seeing how the myeloma is in its true environment and how the myeloma can actually protect itself using the cells around it and the environment around it. So a lot of the times when we do trials that are done in the lab to test new compounds and we see good results, it doesn't necessarily translate to the actual clinical setting. And once we start trying it in patients and in humans, we might not necessarily see the same behavior that we saw in the lab. And that has to do with the fact that it's not really representative of what the environment really is and what it looks like. So the study that we're doing right now using these 3D model organoids is going to hopefully get rid of that problem and be able for us to see how the myeloma cell is in a 3D suspended environment where the myeloma cell can actually interact with other myeloma cells and with the cells that are normally seen in the bone marrow itself. And that way we kind of get a good picture of what the cancer is doing in real life. So when we expose it to different chemotherapy combinations or with new therapies or agents that we're testing, we can have a more realistic result. And that's the whole theory of this study.
So the idea is to not just, so when somebody sends you a bone marrow biopsy sample, you're not just taking out the myeloma cells, you're taking the whole bone marrow microenvironment with the myeloma cell, and then maybe you can explain kind of the basics of what a 3D organoid is, because it's kind of a new term for patients.
Yeah. True. So let me tell you let me explain what an organoid is. An organoid is basically a miniature version of an organ that's produced in the lab from tissue cells from a patient or from a cell line that can be purchased and bought. It has a three-dimensional form. It mimics the organ's structure and function. And up until now, here at Wake Forest and W Firm department has been able to do these organoids and reproduce either pancreas or stomach or lung or liver. So that has helped a lot of scientists study the cell behavior of the normal organs, the biological process, and the interactions of the cells within a healthy organ. So it seemed pretty natural to evolve this technology and say, well, if we can actually build healthy organs and use in healthy tissue from a patient, well, can we actually use this technology and do a tumor. And the way we do this is whenever somebody's diagnosed with myeloma or relapses from myeloma, the most common thing to do is to do blood tests and to do a bone marrow aspirate and biopsy. And the aspirate and biopsy helps us determine what percentage of myeloma is involved in the bone marrow and what mutations it has to give us an idea of how aggressive this myeloma is behaving. And what we can do is with that same aspirate at the time of diagnosis or when assessing relapse, we can take a portion of that aspirate and we take all the cells that are inside the aspirate. So the cells would include not just the myeloma cells, but all the cells that are inside the bone marrow, which is called stromal cells. And they can be endothelial cells and mesenchymal stromal cells. And this combination of cells are then mixed with substances like hyaluronic acid, gelatin, pegda, things that are going to give nutrients to these cells so that these cells can stay alive and continue to interact as if they were still inside of the patient's body. And that's the material that we use to actually do the organoids. So how exactly do we do the organoids? The process is a little bit complex, but to make it simple, once we have this syrup, if you want to call it, of the mix of myeloma cells with all the other cells that are inside the bone marrow, mixed with the nutrients and the hyaluronic acid so that these cells can stay alive, we use a 3D printer, and we inject, instead of using regular ink for a printer, we use the cells with this medium, and we call this a bioink. And then the printer allows to print this substance into wells. And once it's in the well, we fill it with liquid so that it can be suspended inside the well. And by having it suspended inside the well, it maintains this three-dimensional pattern, and it stays as a clump. So you have all of these cells together in a little cluster, and they can survive as a cluster and interact with each other and continue to behave as if they were inside the patient's bone marrow. So that's basically what an organoid is. Now, because we're doing it in very small size, we can actually do many of these just from one single bone marrow aspirate. And that's what makes this concept of using bone marrow aspirates to do organoids a great technique so that we can then study chemotherapy sensitivity and also study mechanisms of resistance. If I can make many small replicas of a patient's tumor with the cells that it lives with in the bone marrow, then that gives me that same amount of opportunities to test different chemotherapy combinations. And that is one of the biggest challenges that we have right now in the world of myeloma. There have been so many new drugs that have come out in the last 10 years. And because we like to combine therapies and do triplets or doublets or now quads, we have a slew of combinations. And there's more than 40 treatment combination options that we can play with at the time of relapse. So which one of those 40 would be the best one to use? We could use
it's so overwhelming.
So we could use cytogenetics, and the cytogenetics can help lead us, okay, you want to focus with proteasome inhibitors, or you want to stay away from these because the patient progressed while they were on this therapy. But you're still going to have a big number of treatment options that you're not going to know which to choose from. And there's a lot of studies that have been published in the last couple of years showing the efficacy of all these novel agents, but all of these studies are comparing one combination to a control. But there are no studies that compare head-to-head what one of these novel combinations would do compared to another novel combination. And if we wanted to see out of all these 40 combinations which one's going to be the best, you can imagine how complex a clinical trial would be, and the number of patients that we would have to enroll in order to get result to see which one out of all of these is the best.
Right,
So,
and even when you're studying them across the board and you're comparing all these different combinations in, let's say, the same type of patient, I mean, that's difficult because your studies, now people are living so much longer, your studies are taking you 5, 8, 10 years. So you have no way of doing the cycling fast enough.
exactly. It's unrealistic to do that. Yeah, I agree. And then it's not representative of what a single patient is going to do and what it's gonna, how it's going to behave. So the opportunity of using organoids to try to find what the best therapy is at time of relapse or at time of diagnosis or at time of the third relapse is a very unique way, because if we can form 30 organoids or 40 organoids or 20 organoids from one single bone marrow aspirate, then we can test that number of combinations, and we should have a result within 5 to 7 days. So then if we get a result within a week of out of the combinations that we tested, which one tends to kill myeloma cells the best and which one tends to kill myeloma cells the least, then we can line them up and say from best to worst and say, okay, if the best combination was this triplet, is there a contraindication for the patient to have this triplet? If there is not, then we can use that combination. If there is a contraindication because they have heart failure or because they have pulmonary hypertension or because they have multiple clots in the past, then you go to your second option or the second best and see if that one has any contraindications. And if it doesn't, then you can use that one. So it's a very nice way of giving the oncologist a nice template of, out of all the treatment options that are available, a guideline as to which one is the best recommended option for them. And you can do that in an academic institution or in a community setting. It won't discriminate where you are if this is something that can be done on a national level.
Mm-hmm. Yeah, I just think this is so needed because myeloma is so different in every one of us, and then it morphs and changes over time, even in the same patient.
Yeah.
So I could foresee at different time points, sending samples to your facility, and a newly diagnosed patient sends a sample, and then they get. I love how you're saying you can see things basically in ranked order, or kind of like a optimal score order, where something looks the best for you is going to kill the maximum number of your particular types of myeloma cells, and then having a second and third and, all these different options. But then when you relapse, your myeloma might not be the same. So you can go back and do it again because you're going to get a bone marrow biopsy anyway.
Correct.
So I just love this idea. So let's talk about some of the details. So when you were saying you're putting it and mixing it with these nutrients and things like that, how long can you keep it alive? How long do you really need to keep it alive to be able to test all these samples against it?
And so right now the tests that we have done, the preliminary tests that we've done, we have kept the cells alive for a week. But what we've been doing is once we form the organoids, 24 hours after, we put a chemotherapy to it, and then we test 1 day and then 3 days after being exposed to chemotherapy to see what happened to the myeloma cells. And that is enough time to see a difference between one chemotherapy regimen and another. And we're hoping that this is going to continue as we expand the project and test more patients. But keeping the cells alive for 5 to 7 days is more than enough to be able to have an answer as to how well the chemotherapy kills the myeloma cells.
And I don't think you mentioned this at the beginning of the show, but I think you might want to expand on it because Wake Forest really had a lot of experience with these 3D organoids, and you brought it to them and said, hey, why don't we do this for blood cancers? Do you want to just go into the depth of the experience that's at your facility? Because I think it's really pretty amazing.
So our facility, Wake Forest has a facility called WFIRM, and WFIRM actually stands for Wake Forest Institute of Regenerative Medicine. And under the leadership of Dr. Atala, who developed this institute, started to do organs like kidneys, heart valves, arteries, and vessels from tissue in the laboratory and using 3D printers and using scaffolds to make these tissues and organs. And that gradually started to evolve into then playing with miniature versions of these, and that's how organoids started to develop. And Alexander Skardal, who is the scientist that I work with and leads the organoid, I guess has the most experience with organoids here at Wake Forest, is the one that started to play with solid tumors first, and he actually has some experience with. He started testing with mesothelioma and see what happened with mesothelioma, and he also tested with another type of, I think it was a pancreatic cancer, if I'm not mistaken. I don't want to mess the information up. But when he was telling me about that information, that's when I said, well, that sounds great, but the difference between a solid tumor and a liquid tumor is that in a solid tumor, you need to do surgery in order to get tissue, and you cannot be going back and forth and doing surgery repeatedly and kind of have different have a time lapse as to how the tumor is doing. But the beauty about blood cancers, whether it be leukemia, multiple myeloma, or lymphoma, is that a bone marrow aspirate can be done at any time. And yes, it is invasive. And yes, patients hate me for doing bone marrow biopsies. But it is not as invasive as an actual surgery for, let's say, lung cancer or mesothelioma or something like that. So that's a year ago is when we started to play with myeloma cells. And we had a very hard time keeping the myeloma cells alive using patients' myeloma cells and the patient's stromal cells. If you combine myeloma cells that are off the shelf or are cell lines, these are cells that are not coming from patients but cells that you can actually purchase and are we normally use them for testing. That's a little bit different because those cells are already immortal and they tend to stay alive very easily. But a patient's myeloma cells, they haven't become immortal yet, and those are harder to keep alive. So it took us about a year to be able to find the good combination of nutrients and hyaluronic acid to make sure that these cells stay alive long enough so that we can then be able to test the different chemotherapy combinations and be able to get our results. Otherwise, we would get all the wells that the cells died, but they were all dying regardless of whether you put them on chemotherapy or not.
Makes sense.
Yeah,
that makes sense. Now, you kind of went through your process a little bit, but maybe you can go into more detail about the process. So you're starting, I'm assuming, with patients at your own facility.
Correct.
For samples. And then are you doing just relapsed patients to start, or who will you start with?
So at the moment, I think the people who would benefit the most would be the relapsed patients until we perfect the technique a little bit better. And I'm going to tell you why. It's not that I don't want to short sell the newly diagnosed patients, but when you have a new diagnosis of multiple myeloma, the chances of having a response with the current therapy is excellent. It's more than 90%. Whether you use a combination with bortezomib, lenalidomide, and dexamethasone, or if you use carfilzomib with lenalidomide and dexamethasone, or if you're in one of the clinical trials that are adding a monoclonal antibody to these backbones. So the majority of the patients are going to have a great response to that. And in a setting like that, if we were to test 30 different combinations, odds are that all 30 combinations are going to give us a very similar result. And the difference between one combination and another is going to be so small that it's going to be hard to measure the difference. So if we focus on relapse patients instead of the newly diagnosed, then we're dealing with a little bit more complex disease. And in relapse, then you start to have more variability in terms of how people are going to respond to the chemotherapy combination. So if we test different chemotherapy combinations, then we are going to have more variability in terms of the efficacy of the therapy, and we're going to be able to have a more reliable way of measuring differences between one combination and another combination. So at the moment, we'd like to start with relapse disease, and it can be the first relapse, second relapse, third relapse, or any amount of relapses. But that way, we can calibrate things a little bit better. We can make sure that the process is done properly, so that once we have that mastered, then we can zone in more into detail and go and tackle the newly diagnosed myeloma. We can always test newly diagnosed myeloma patients, and we can have that as a baseline. But I don't think we're going to have any result in newly diagnosed patients at the moment that are actually going to change or impact what therapy we're going to use. If you talk to a myeloma doctor and you ask them, what's your first frontline therapy, the majority are going to give you one of three answers, either VRD or CyBorD or carfilzomib, lenalidomide dexamethasone. And nobody veers off of that unless they're very frail or they have medical conditions that prohibit the triplet regimen. But the relapse setting, that's when things get tricky. And that's when everybody starts to wonder, okay, what is next? And that is the big headache for the doctor in terms of choosing the next regimen. It's a new blessing for myeloma patients because before we didn't have that many options. But at the same time, we don't know if the one that we're choosing is actually the best one for that particular patient. So a tool like this is going to help avoid giving therapy that can cause toxicities or side effects, and then 2 months down the road, realize, oh, this was not the right combination. Let's go back to the drawing board and try a different combination.
Yeah, I mean, the time that the side effects and the cost and just the time to have your disease grow out of control is this seems to be so much more efficient than that.
Mm-hmm. And we're hoping that this, once it gets validated, it can become a standard of care. So what we've done right now with the samples that we've tested is on purpose we have kept them overnight sitting in our lab and have not done the tests until the next day. And the reason why we did that is if this test does function and is something that we can actually take to the clinic and start using it in patients, we want to be able to offer this test to anyone who has myeloma. So let's say somebody in California or somebody in Fargo or somebody in a big city, anybody who is anywhere in the United States has myeloma and they do a bone marrow biopsy, they can always overnight the sample and we can process it the next day and be able to give reliable information.
Right. And Dr. Gabriel started doing this with her P-Crowd study, and it works really well. You just send them a sample, and they send it back to you, and you just make sure you don't get your bone marrow on a Friday.
Exactly. That is very true.
So you can run the test on any other day during the week. So it's awesome. So you talked a little bit about how you get the sample and then how you grow it up and what you do with it. And then we talked about the time frame a little bit. And in your proposal, you talked about evaluating the tumor markers at different time points of the tumor. What do you mean by that?
So there's several things that we can do when we're playing with a model like this. One is something that patients are going to want and benefit the patients the quickest or the best is know what is the best chemotherapy for that particular patient. But the other thing that we can take advantage of is because we're replicating the environment of the bone marrow, with the myeloma cells in it, we can actually study the behavior of the myeloma cells with its environment. And let's say we tested 20 different combinations in a particular patient. We want to do at baseline, before we actually expose them to chemotherapy or anything, we want to do testing for tumor markers and gene expression to have an idea of what that cancer looks like. And then after exposing it to chemotherapy, we can see which combinations work the best. But the ones that didn't work, then those organoids, we can actually repeat the tests and see if there were any changes in the genes, or if there were any new mutations, or any changes in the surface markers of the myeloma cells that could explain why the patient was resistant to that combination. And by getting that information and comparing it with the baseline information, maybe it can shed some information as to, is the cell being changed as it's being exposed to chemotherapy and developing its resistance, or is there something else? Are we just choosing the strongest cells? And that can hopefully shed some light as to more mechanisms of resistance of the myeloma cells.
Well, that makes sense. Like, did the chemo actually change the cells so that they're behaving differently?
Yeah.
That makes a lot of sense.
Because we know that we know that when myeloma relapses, that it has a whole slew of new mutations or different mutations, and as it tends to come back and as time progresses, there's going to be more evolution in the myeloma itself. But we don't know exactly if the chemotherapy or if the exposure to the chemotherapy alters the cell at that moment, and if there's anything that we could potentially identify to help prevent that resistance.
That's amazing. And then you're testing the tumor against how many different drug combinations? And then are those existing drug combinations, or those clinical trial type? Could you test a BiTE against it, or a CAR T, or antibody drug conjugate, or things like that against it?
So right now, we would like to focus on existing chemotherapy combinations for this particular study. And the reason why we want to do that is the same time we're testing in the lab the chemotherapy combinations, the patient whose sample we got is going to be getting chemotherapy of some type. And we want to be able to go back and compare how the results in the lab compare to how the patient actually did with the treatment that they got. And if we started to play with novel therapies or things that are not standard, then we wouldn't be able to extrapolate that with what the patient actually received. Now, that doesn't mean that we cannot play with new compounds or BiTE therapy or CAR T. We can definitely do that, but that is something that we will probably do with a separate study or a separate grant, because it is true. It would be very silly of us not to take advantage of this model and be able to test new combinations or new compounds or such things as BiTEs and CAR Ts to see how it's going to behave more in a real-life model compared to a typical 2D model. So drug companies are very excited about this study, and they actually have reached out to try to do some collaboration and also to compare the results that we obtain with the results that they have obtained using the standard models that they used when they were testing drugs, and see if there are any differences that might warrant further testing with these new models.
Yeah, well, you can imagine that it would cut their drug development significantly if they can start testing some drugs that are in development against these samples and just kind of see what kind of responses they have. That's amazing.
I mean, imagine you could potentially even skip testing in mice and stuff if you're seeing such great results and you're actually validating data with these organoids. I mean, that would be such a great breakthrough. I don't know if we can do that right now. It would definitely take a long time for science to take such a big leap, but hey, who knows?
No, I think it's a great theory because a lot of people say, well, we can kill myeloma and, we can kill a lot of myeloma in a lot of mice. But then once you start using it in human studies, then it's usually different.
Exactly.
And then part of the process, so you test the sample, you do a gene expression profile test, so you're testing the genetics. Then you're evaluating the responses after 1 day and 3 days, like you mentioned before. And then do you do another gene expression, or do you just do one?
So we are entertaining the possibility of doing the gene expression or RNA sequencing at the end, but we would only use the organoids that were very resistant to chemotherapy. And the reason why that is you obviously need to have live myeloma cells in order to test them. So we would be focusing on those chemotherapy combinations that were not effective. And hopefully that will give us a better answer as to why that is, what's happening that could potentially explain us the mechanism of resistance.
Yeah, that makes sense. Okay, let me see. Well, I had a technical question, but I don't know if it's worth answering or not because it was a chemobiogram, and that was in your proposal, but I didn't know what that meant.
So that's just me playing with words. And the reason why I use that word is basically if somebody has a urine infection or if they have a blood infection or a skin infection, the first thing that we do is we take a culture, or we do a culture of either the urine or the blood or a swab of the skin. And when we send it for culture, a lot of a percentage of the time, not all the time, but a percentage of the time, we get a result back with an organism that's growing, a bacteria, or normally the bacteria that's causing the infection. And then it also, the laboratory also gives you a result as to what antibiotics it is sensitive to and what antibiotics it's resistant to. And that is called an antibiogram. Which of the antibiotics are sensitive to this and can kill that infection.
Oh, I get it now.
So it's a play of words with the chemotherapy and trying to form this chemobiogram for myeloma itself and see which combination of chemotherapy is going to kill this better and which ones are going to be more resistant to it.
Okay, that makes a lot of sense. I had a question because I've heard a lot of myeloma experts say, you can have maybe, let's say you have a really big lesion in your shoulder and you're doing a bone marrow biopsy, that the genetics of that myeloma can be different in your shoulder than it can be coming out of your hip. How do you deal with that when you look at a test like this? Is the sample that you're getting kind of representative of that myeloma, or would you ultimately maybe just go get 2 samples?
That's an excellent question, and it's very true. Arkansas actually did a study, and what they did is they did imaging studies, and wherever they saw lesions, in whether it be plasmacytomas or lytic lesions, they went ahead and they biopsied each one of those lesions and did a bone marrow biopsy, and they compared the results. And the results were pretty interesting because you could see that there were different clones of myeloma and different mutations in different parts of the body, which goes with the name multiple myeloma. You're not dealing with just one myeloma, you're dealing with many. So right now we rely on one bone marrow biopsy to tell us what mutations the patient has, and we go off of it. And a lot of the times, if we do a bone marrow biopsy, it might tell us that it's, let's say, 60% bone marrow involvement with myeloma. But there's a good chance that if we did a biopsy next to it or on the other hip or on the sternum, we might actually find a different percentage of myeloma cell involvement and also different mutations. So that raises the question, so what do we do? And we're not going to be poking all over the body for a patient because patients
really
already. I mean, one single bone marrow biopsy is painful enough. Yeah, I don't think somebody would want to be willing to do that unless they like torture.
Yeah.
So At this point, we do have to rely on one bone marrow biopsy, and we need to make sure that if we get one bone marrow biopsy, that it is a very adequate sample, and that it has good cellularity, and that it has a good representation of the marrow itself. If the bone marrow biopsy is a suboptimal sample, or if it's just the cortex of the bone, or it's crushed, or there's a lot of artifact, or it's a diluted sample, then I would encourage to repeat the bone marrow biopsy so that we can at least be dealing with a good sample, knowing that it might not be representative of all of the myeloma in the body, but it'll help us at least hopefully identify mutations that would help us with prognosis. So, going back to your question, I don't think it would be prudent at this time to be biopsying everything. If there is a different lesion, or if you receive treatment and then you repeat a PET scan to check for response, and you see that there's an area that is not responding to therapy, then that area would warrant a biopsy so that we can learn what's going on in there. Is it a more aggressive type of myeloma? Does it have different type of mutations? So that it can help us guide us in terms of what therapy we should be using to target that. And going back to when we were talking about targeted therapy, it raises the big conundrum. If we're relying only on one bone marrow biopsy and it might not be representative of other parts of the body, are we doing a disservice just by using a single targeted agent? And I think that it's true. And I think that's why combining targeted therapy with more generic therapy is probably going to be the answer going forward.
Yeah, that really makes sense. Well, I'm glad you're thinking about that, because I know it's confusing and frustrating that this disease is so complicated.
Yeah.
But it is what it is, right? So
yes, it is. And hopefully those liquid biopsies might be able to change things in the future. I mean, that's something that everybody's looking forward to, and we're hoping that it would be representative. We're not quite there yet. Still needs some tweaking, but hopefully it will be a changer in the future.
Yeah, because you could take that same sample, right, and use it in your organoid model.
Exactly.
You would think so. How many patients? So for this particular project right now, how many patients are you planning to test? And then, when do you expect to have certain results? And I'm just assuming you're not going to do shipped bone marrow biopsy samples from the get-go. That might be later on.
So we're wanting to do 40 patients at the moment. And the way we're going to be doing this test is, if a patient gets a bone marrow biopsy, we take an aspirate, we process that aspirate with the organoids. We get a result from the organoid by the end of 7 days, and we're going to keep that information there confidential. In the meantime, the patient is going to be getting therapy, and at the end of 2 cycles of chemotherapy, we're going to see how they responded to treatment. And at that point, we're going to compare it with the organoid result. And that way, we can start doing some type of validation, but at the same time, not influence results with the patient nor with the lab. Because at this point, even though we're very tempted to, if we see that one regimen is much more effective than another, and try to use it with the patient, it doesn't necessarily mean that it's going to translate to the patient. We need to make sure that this test is validated and that the results that we get actually do translate to what's going to happen with our patients. And so every 2 months we will have results from that. So the patient that gets enrolled, we should have results of that particular patient in 2 months. So the amount of time it takes us to enroll these 40 patients, I'm hoping that it'll be within a year, because I don't see why.
I think this is not going to take a lot of time.
I don't think so either. I think people are going to be excited to volunteer and to be willing to donate some of the aspirates. So I'm hoping that we will have results and everything much less than a year and be able to present some preliminary data halfway through and go from there.
Yeah, that would be fabulous if you could do that.
Yeah.
So is this ultimately going to become like a commercial type of test that you could run, kind of like they do, the Skyline test or the MyPRS test or other types of tests? This might just be another type of test, right?
Yes, this is our goal. Our goal is if this organoid works to tell us which is the next best therapy in somebody who has multiple myeloma, then we want this to be available for everybody. And we would start providing it here nationally and make it commercial. And I know that we're not the only site that has organoids. We might be the only site at the moment that I'm aware of that actually plays with patients' myeloma cells with patients' stroma cells and doing this test. But I know that there's other sites here in the United States that have some ability to do organoid. And if this does work and it's validated and we want to commercialize it, we can always then expand it to other institutions or other labs so that it could be available nationwide. And even if we cannot expand it to other labs at the beginning, it can always be shipped overnight, and we can process the sample and then give an answer 1 week later. And then eventually move it to move it to globally if possible. But yeah, the idea of this is to not just keep it here, but to share it with everybody so that everybody can benefit from it.
Yeah, it's wonderful, and I think that would really change the course of this approach for personalized medicine, or even just optimizing with what we have today.
Exactly.
Now, each of these projects are integrating with HealthTree. Do you want to describe just how you might integrate this with HealthTree?
Sure. So HealthTree, what exactly is HealthTree? It is a nice platform for a patient to be in control of all of their information. You have in HealthTree a patient's personal data, patient's disease history, whether it be laboratory numbers for myeloma markers like M-spike and light chains and CBC, CMP, bone marrow biopsy, imaging studies, and you have all this information throughout the course of the disease. And at the same time, HealthTree allows you to put the different chemotherapies that you've been exposed to. So one nice way of incorporating the results in this study with HealthTree is that every time somebody has a bone marrow biopsy, we can perform this chemobiogram test using the organoids, and it will give a result of a large number of combination therapies that are going to tell at that moment what it's sensitive to and what it is not. So that can be incorporated as part of the HealthTree disease data so that anybody who is managing that patient can look at the chart and say, oh, in the first relapse, the patient received a combination with, let's say, a proteasome inhibitor and a monoclonal antibody and dexamethasone, or an immune modulator with a monoclonal antibody and dexamethasone, but the patient also was sensitive to all these other combinations. And then when they relapsed the second time, the study showed that all of the ones that the patient was sensitive to at the first relapse, half of them are still sensitive, or none of them are sensitive. But some of the ones that were resistant are now sensitive. And that is going to help the physician have a 360 view of the disease. Right now, we rely only on, okay, the patient relapsed, got this therapy, they responded, or they were resistant to it, or they stayed in remission for 2 years or 6 months, and then they relapsed again. So it's a linear view that we're seeing of the disease. But information like this with the chemobiogram and the organoids, it's going to give a more 360 view of, okay, that's the path that they took, but these are the other paths that could have been taken. And out of those paths, when they relapsed again, some of these paths are still available and can be options, or they haven't. They've changed drastically. So that's one way that can help with HealthTree. But then another unique way that it can help is, and hopefully this will not be the case, but let's say somebody relapses and gets a bone marrow biopsy, and they get treated, and we do the chemobiogram and the organoid testing, so we have a list of chemotherapy combinations for that patient. And then down the road, they either become intolerant to the chemotherapy, or they have a reaction to it, or they relapse, but they can't get a bone marrow biopsy. They can always look back at the chemobiogram or the results of this test and choose something else from that combination. Because the reality is that there are some patients that are going to have intolerance to a therapy, or are going to react and get a rash or diarrhea or too much nausea or get too weak. And I would hate for them to require another bone marrow biopsy. So you can always go to the results and choose the next one in the line of options.
Right. That makes a lot of sense. Well, this is such a fascinating project, in my opinion, because it really gets to the heart of the issue for patients. What do we do next?
Exactly.
It's so difficult to figure that out, and you just wonder, are we choosing the right things? And I just feel like each time we're making these decisions, we're making these life and death decisions that really affect the future and some of our potential opportunities for treatment. So getting it right the first time, anything we can do to help accelerate that is just what we want to do. So I will open it up for caller questions, and I know we're at our time, so we'll ask people to keep it short. But if you could call 347-637-2631 and press 1 on your keypad if you have a question for Dr. Rodriguez, and we will start with caller at 983-6757. Go ahead with your question.
Hi, Jenny. It's Dana Holmes. Thanks so much for taking my call. Appreciate it. Hi, Dr. Rodriguez. Your out-of-the-box research is just so very much appreciated and super exciting to know we may one day put those little mice out of business and actually move the clinical trial research timetable dial to fast forward. It's just so exciting to have listened to your presentation. I'm always so baffled by the standard of – I'm a smoldering patient, so I'm really in the phase of just trying to learn about all of my potential treatment options going forward when I'll need to make those decisions. And I always am so baffled by that one-size-treatment-fits-all approach, or, let's see what sticks to the wall treatment approach that we currently are really stuck with. I understand why, because the field continues to obviously learn more, but it still remains baffling. So thank you. As I stated, I'm a smoldering patient with a primary predominant 11-14 abnormality. So my bone marrow biopsies have not really detected any others yet. And I understand that that's likely they just haven't hit the right spot to extract the subclonal cells that are probably lurking about. So I appreciated your explanation of how you are trying to overcome this uneven distribution in the marrow. And just for the record, as a patient, I've already gone through 4 bone marrow biopsies. I know that pales in comparison to many of the myeloma patients, but as unpleasant as they are, in my experience, the experience of the practitioner matters. So multiple sample sites would be agreeable to me and probably a lot of other patients to capture optimal distribution of these cells. So I'm just really kind of throwing that out there for you to consider, because I think it's important for patients to understand that, these are unpleasant practices, but they're necessary to really help you brilliant researchers help sort it out. So there are many of us that are willing to be poked numerous times. So can you actually foresee doing the chemobiogram testing earlier in myeloma? I know you said that at this point you're really focusing on the relapse patients, but I honestly, from my mind, to be able to avoid the standard of care approach, which is really that one-size-fits-all that I respect and understand would likely work for a majority of newly diagnosed patients. You know, if I can avoid that step, I'm all for it.
Yeah. So I think I definitely see us playing early on in disease staging, and I think that after we understand chemotherapy in myeloma, playing with smoldering myeloma and playing with MGUS, which I know is something that people are going to think, well, what the heck is he talking about? But I think that's where this is going to be very key. And MGUS and smoldering are going to be unique things, not so much in terms of chemotherapy, but in understanding the biology of the disease and trying to understand what it is that makes that MGUS jump to smoldering or what makes that smoldering jump to active myeloma. And if we can find something that we can trigger early and prevent it from evolving, that would be, that'll be the goal, the jackpot.
It really, it's like the holy grail, so to speak. It really, really is.
Now, right now, I have to be honest, and I have to say that one of the limiting factors in playing that early in the disease is that in order for us to make a good organoid, we need to have a good number of cells. And so that's going to be something that I haven't looked at yet, but we are definitely considering as we go forward to try to find a way to make sure that we can do a good organoid with smoldering and a good organoid with
Now, when you say
MGUS.
a good number of cells, are you saying percentage-wise? Like, in other words, I'm told I have 20% myeloma cells based on flow. So do you have more or less a metric to make this a successful test?
Yes, exactly. Because let's say somebody has a very small percentage of myeloma cells, and we do the organoid, and we're starting with, and just to give an example, we're starting with 10 myeloma cells. Then when we compare after exposing them to therapy, we're going to have very little cells to play with and to kind of make a good measurement. So that's the one thing that is we're going to have to figure out how to play with for MGUS and people who have low tumor burden.
I mean, it would be incredible to think that someday you could do this on a smoldering patient, even earlier with an MGUS patient, who ends up progressing. That we would actually have a roadmap to follow to initiate treatment beyond standard of care. You know, standard of care is wonderful, but it's certainly not curative. And, hopefully we could get closer to that goal with this type of testing. So it's fascinating. It really was. I was so excited when I was listening to your explanation. So I for one, would love to be able to follow your research. Do you have any sort of website or something that you're going to be sharing updates on? Are you going to be doing it through HealthTree or give Jenny regular updates?
So I don't have a direct website to give updates, but I can definitely give Jenny updates, which I'm sure she would be glad to
we'll
share.
Those for sure.
Great, great. Because, if you open up a study for smoldering patients, I think it's fascinating. So many of us would jump at the chance. I'm enrolled in the P-Crowd study, and I've already donated 2 bone marrow samples to them, and I'm probably on my 14th blood sample to them. You know, it's important for me to help. Well, it's important for me if I want to find, the real help down the road. It's important for me to give you guys these samples for, it's really nothing exciting for me to do. It's, just my standard of care. So I look forward to really keeping on top of this and see what you end up discovering. So thank you.
Thank you. And thanks to donations that help fund research like this, we can be able to explore other questions that come up as we start doing this research, because I'm pretty sure that this is going to generate many more questions.
Oh, absolutely. It always does. One door opens up 10 more in myeloma, it seems. But, it's a terrific starting point, that's for sure, and it's an exciting starting point. So, I donate to the multiple myeloma, to the Myeloma Crowd Research Foundation, and it's just a worthy cause. I mean, patient-driven. It's just been terrific because, Jenny wants a cure too. She wants to be around, and she's really our incentive. So it's just been terrific, and thank you for collaborating, and thank you for applying for this grant, because it's super exciting. So good luck to you, and I look forward to really keeping track of your research. Thank you, Jenny, for entertaining my long-winded set of questions. Appreciate it.
Sure thing.
Take care, everyone.
Thanks, Dana. Okay, bye. Dr. Rodriguez, thank you so much for explaining your work. It is just absolutely outstanding and excellent, and we're so thrilled to see what you learn from this. We will, for sure, be giving regular updates on your project. And so when you have information, please feel free to reach out. We will also be creating a short video about his work, so you can watch that later, and we'll be including that on the campaign link that we talked about earlier. So we appreciate you considering sharing these types of projects, because family and friends, they want to know what they can do for you, and this is something that they can do for you. They can help. So we thank you for joining us so much.
Thank you. It's been a pleasure.
And we thank you for listening to Myeloma Crowd Radio, and we encourage you to tune in next time to learn more about myeloma research and what it means for you.
Hey guys, it is Ryan. I'm not sure if you know this about me, but I'm a bit of a fun fanatic when I can. I like to work, but I like fun too. It's a thing. And now the truth is out there. I can tell you about my favorite place to have fun. Chumba Casino. They have hundreds of social casino style games to choose from, with new games released each week. You can play for free anytime, anywhere. And each day brings a new chance to collect daily bonuses. So join me in the fun. Sign up now at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.